Well, terrific presentations, all of you. Thanks for your remarks. And Catherine Wales, are you still on the phone, just so we know you're there?
I am, yes.
Terrific. All right, well, Gianluca had to sign off, but we have four of the other sponsors here, so the floor will be open for the committee members to ask any questions you've got. I will kick off with one just to give people a little more breathing room. Um, we've had some interesting conversations already in the panel about the boundary between quality and financial security. The UHC trend in the world is broadening coverage. There's some evidence still that people have significant barriers of getting actually the care they need that are related to financing, financial risk, and security. We are interested in the sponsor's views of that problem. I can give you more texture to the question if you need it, and whether you regard that as kind of inbounds and important for us to address or not. What was your hope and intention around financial risk as an issue?
I'll take that, I guess, first. It's interesting. I think it's very important to the issue of quality. I think one of the things within sort of the world of health system strengthening is we sort of bridge between, especially in our office, we have economists, we have public health specialists, we have, a range of different disciplines. And one of the things that I talk to our economists about all the time is I think they look at the financing issues from sort of equity of financing. Does everybody have access to care? And they sort of stop there. And I always say you have to go to the health outcomes. It's not just about aligning the financing, but you need the financing to align to achieve the outcomes. And I think that that's an important area that sort of gets lost in the intersection between sort of economists and public health professionals. So a lot of times you have public health professionals who are concerned about the outcomes and don't necessarily address the financing issue. And then you've got economists who are concerned about aligning sort of according to a financing framework, but not necessarily getting all the way to making sure financing aligns to outcomes. And I think it would be really important to try and start bridging that space.
It's really helpful, Kelly. Anyone else want to comment on it, Anne included?
Yeah, I think
Please,
if I'm
Peter.
understanding the question, I'm not sure that the committee wants to get too far afield of the health area, and so would want to focus on the health outcomes, and clearly recognizing that there's socioeconomic factors, financial status, education, et cetera, that would go into that. But I would imagine that the committee would primarily focus on health and on the health outcomes, and I guess what's within the bounds of control of the sponsors or of the readers of the of what the report would be.
Thanks, Peter. Niraj?
So I guess a question in a similar vein that we have a few months to deliver this report. Is there anything which we shouldn't focus on? Like, are there, can you rule out some things where you say, we know these things are important, enough has already been said about it, you guys don't need to spend your next few months deliberating on it. So could you kind of try to give us some direction on, what you think is not important, and then, and maybe if there is just one thing that is very important to you, what is that?
Sure, Ashish.
To give you guys just a moment to think, I mean, look, I think there are a bunch of interrelated issues, right? There's access, financing, quality of the healthcare services that are delivered, and where we draw those boundaries, there's nothing magical. They're all important, right? You don't have access, you have terrific quality, but no one can access it. That's a problem. If nobody can afford it, that's a problem. So we acknowledge as a committee that these are all incredibly important issues, and we've been thinking about where to draw the boundaries, because in limited time, we're going to be the broader we are, the less effective we are going to be on any one area. And so I think we're looking for a little guidance from you about where to draw the boundaries. just in terms of how you guys think about it. And so, the friendly amendment I would put on Neeraj's question is not what's not important, but what's really important that you still don't want us to deal with, because if we deal with everything that's important, we're not going to get very deep into anything. So acknowledging that all these issues are important. What's important that you say is important, but it's fine if you guys don't focus on it because we want you to focus on something narrower. Is that fair?
Yes, you're my new spokesperson.
And do you want to take the ball on that by any chance? And you can say no.
Sorry, no, I have just a quick point, and I don't know how much of the paper was planning to get into this, but I think a key piece to focus on or to maybe think about as a framework is really aligning, which I know is the big challenge here, aligning the different stakeholders on quality. So understanding what does quality mean to politicians, to ministries of health, to patients, to clinicians. And I think especially there always seems to be a disconnect between patients, like what they value from a quality perspective, and clinicians and what a clinical outcome is. And also looking at what funders and investors are maybe looking at from a quality perspective, just to see if there was a way to get consensus, making sure that all the right pieces of the kind of the chain are aligned on that. I know that that's not an easy task, though.
Thank you. Peter?
I'll jump in just to say these are very difficult tasks and questions, and I would be challenged just within the NIH institutes and centers to say, here's what we think is the most important and to focus on with just the diversity of stakeholders within NIH and then across the different supporters of the panel. I think that would be a challenge. So I'm sort of going to, for myself, punt it back to you and ask, in the time that you have and the expertise that you have to focus on this, to try to determine that. I maybe just speaking in my own capacity, I think the perspective would be what's going to achieve the greatest improvements in health status at the population basis, and to use that as really the goal of what we're looking for and what the focus should be on.
Great guidance, thank you. Kelly, looks like you have a couple.
I'm going to endorse what Peter said, but I'll just build on it myself and add to the fact that I think if you can identify common approaches that can cut across a range of issues, I would focus on that and really bringing that out, and then things or aspects of quality improvement that might apply more narrowly to one part of the health portfolio or another, I would put less importance on, because I think the idea is where can we draw sort of broad lessons learned that we can take and apply to our programs more generally.
Thanks. Other committee members have questions? Yes, Sonia.
Thank you very much for those excellent presentations. I have two sets of questions for you. Well, firstly, if you look at the frameworks, the quality assessment frameworks and the health systems frameworks, there's a lot of overlap, but then there also isn't overlap. If we take the NASEM report as as the basis on which to build further our work, then there are 6 dimensions of quality clearly outlined, which you have also referred to. But Kelly, you talked about health systems a lot, and you know that health systems, there are 3 intended outcomes of a health system, which are equity in health outcomes, financial risk protection, and patient and responsiveness. And then on the other hand, there are the 6 health systems building blocks. So my question to you is, A, where do you see the intersections? And B, since the Quality NASEM report has focused on those 6 dimensions at the patient interface, do you see those dimensions also being important at the systems interface? Because they're 2 very different things. That's one question with different components. And my other question is fairly simple. We keep reading literature on quality which talks about the same things over and over again. I mean, empirical work will talk about the same things in different parts of the world. And just to highlight 2 examples to pull threads from what you have said, absenteeism, stockouts. Is there an appetite on your part to understand why do these things happen? Because a lot of us come from the developing world and know exactly why these things happen. And those causes of the causes and the actual determinants, the the upstream determinants have not been the focus of empirical work, especially when it comes to the lack of transparency, accountability, and gaps in integrity. Is there an appetite on your part to understand those determinants better? Thanks.
You want to start, Kelly?
Sure. Okay, let me see if I can organize my thoughts here. So, first, I think starting with the dimensions of quality and the health system's outcomes of equity, financial protection, and responsiveness, I think they overlap pretty completely. I think at the end of the day, if the point of health systems is to ensure good health outcomes across the population, then the only way you're going to ensure good health outcomes is if you're providing quality services. And so, I think they do intersect pretty nicely. I think I talked about especially from an equity basis, where I think equity is a key, or inequity would be a key indicator of differences in quality across a set of services within a country. I think in my previous example, I perhaps not perfectly eloquently talked about financial protection, and I think revenue generation, risk pooling, sort of the means by which we pay for services, are an important part of who receives services, the resourcing of those services, what sort of supplies and tools are available. I think those need to be part of a quality conversation. Otherwise, I think you're missing a big piece of it. And so how does that financing align to help achieve quality of care? I don't necessarily know that you need to go beyond that to the full sort of set of what is financing, but I do think we need to acknowledge that how health system is financed is going to impact the quality of care within the system. And then responsiveness, I think, is very much, as several other speakers talked about, is that patient view of quality, right? And so I think to the extent that patients view or experience quality in one way, that will inform their opinions about responsiveness. So, again, I think with the patient interface versus the systems interface, I think you're right. There are more upstream things that are farther removed from that than others. But I think that you also need to think about what is influencing that patient interface, and whether or not adjusting farther, maybe not all the way upstream, but some upstream things are going to have an impact on patient interface more so than focusing directly on that interaction. I think it's an open question. I think you could take a look, but if there is a way to figure out how far back you need to go, or what distal factors might have the biggest impact on that patient interface to achieve quality, I think would be really useful. You asked if there's an appetite to know sort of why these things happen, sort of absenteeism and stockouts for the example you gave. I think I'd agree with you. I think we have a sense of why they happen. I think the bigger question is how to stop them from happening, and what to do about them. So I think absenteeism, we know happens for a whole host of socioeconomic reasons, and care for families, and that the same health workers have the same challenges as their patients with arriving at health facilities. But are there ways that the system can organize to help those issues, or can we figure out what are the root causes of those issues and address them? So I think less sort of why do they happen empirically, but more is there empirical evidence that would tell us which approaches would help address some of the issues.
Yes, Peter.
Yeah, just to add quickly and to see if the chair will allow any of my colleagues, either Stephen on the phone or those present, to also chime in.
Absolutely. The answer is yes. I'd welcome it. So please.
Good. So just for my own part, I mean, my understanding is that your primary charge is focusing on the patient-provider interface, which seems like an important place to start, and you could spend more than the months and time and expertise you have allotted just on that. But in answer to the question, I would say to go where the information leads you, and if you see more upstream factors as really being primary and really helping to improve quality, to include those, to add those. And I think adding to absenteeism, there's also issues of we provide incentives for providers to attend trainings, and sometimes they spend a disproportionate amount of their time, and maybe we should provide incentives for them to actually be at their posts and to have that rewarded. Also, the issues of even broader issues of ghost workers and other such things, I wouldn't think would be the primary focus. But if that's where your research leads you as to being really a primary, those kinds of things as primary determinants of quality, that I would think those should be included.
Yeah, the charge doesn't limit us to the interaction. It asks us to what does it say? Something like especially with respect to put the emphasis on. So we're not barred from these other issues. Other colleagues you'd like to draw in?
This is Dr. Michael Engelgau from NHLBI, Heart, Lung, and Blood.
Thanks, Peter, and thanks for giving me a chance to comment. Very tough questions, and I, like Peter, I'm not prepared really to hedge on what you should not do. I think that's a great question, but maybe something that you can maybe, with your scan of all the different things, prioritize there. But just a couple things that come to mind, I think, that are going to be really challenging. The first is realizing that quality is kind of a context-oriented thing, and we'll be going into many different contexts. And how can we think about the different contexts as we undertake our quality efforts, and specifically for NIH, the research piece of quality in different contexts. And I hope that comes out with some kind of strategy to do that, or a way to think about it, and it'll be very important for a research agenda. The second thing, and this goes back to Sonia's comment about determinants, and determinants, I think, of quality are very important, but what I would want to think is that we wouldn't focus on them just so much as what the determinants are, but think about how, in a research context, we could use those to develop strategies around, and so specifically modifiable determinants and things that we could understand better, so that they could be worked into not only the research agenda, but also the interventions that would end up being implemented to improve quality.
Much obliged. Peter, anyone else that... Mohammed Ali.
Yeah, so I'm really curious as to how the sponsors see the issue of value, and whether you see it as a part of quality, or you see it as a separate issue in terms of how we conceptualize the issue of quality. And the second is whether you incorporate preventive services into quality of care or not, or you see them as, again, a separate issue.
Well, I can start off in replying. So this is getting a bit afield of the primary focus of NIH's work, but certainly things that are shown through research proven to be ineffective, or that in their implementation are ineffective, wouldn't seem to be adding to quality and in the health outcomes. So I think that would be my comment regarding that. And as far as preventive interventions, absolutely. And the example that I gave for the cancer field included prevention, and most of my own work and the work of other work of NIH in HIV prevention, whether it's voluntary medical male circumcision or pre-exposure prophylaxis or other interventions, would be part of a health system service. Yeah.
The CASM report was very clear that waste is poor quality, and even early conversations raised the question as to whether that is going to be an object of our study: overuse, wasted effort, ineffective care. And you're nodding your heads that that's in bounds for you too.
Yeah, I think I would also add, it was sort of on one of my slides, but I didn't touch on it, but I think within the sphere of prevention, there are certainly quality issues. I mean, I think one is just the fact that prevention helps alleviate other quality. But if you look at, for example, breastfeeding and whether or not a woman breastfeeds is one potential question, but whether or not they breastfeed exclusively for 6 months and whether or not they're also providing supplemental, water or foods are really quality issues around the one act of breastfeeding that I think it is important to figure out how do we ensure not only that women breastfeed, but they're all breastfeeding at, the highest quality that they can, because that does have important impacts on health outcomes. So that's I think one sort of key example that comes to my mind where prevention really does matter for quality.
Thanks, Kelly. Yes, Steve.
I may just add one more thing. At PEPFAR, we're interested in having a wide assortment of preventative measures to prevent HIV that are all patient satisfying. So to be able to offer a number of different services, I think would help quality of care in our eyes. Yeah.
Thank you very much. Anne, do you have any comments on this? Great. Any other?
No, I mean, I think everyone's saying it. Oh, sorry. I was just saying, I think everyone's saying it well, but I do think that value and understanding cost effectiveness is very important, and as much as possible to not try to overcomplicate it, which I know there's a million rabbit holes that we could go into with this, but really trying to come up with some clear direction.
Thanks, Anne. Yes, Jeanette.
I have another question that is more kind of a structural. How open are you to come up with innovative strategies that are not really in the current landscape? Because it's very. I mean, we can compile the thousand of recommendations and then try to be smarter, or we can really look at what we need in a health system that is not probably the one that we are analyzing now. And for us, I think that's quite important because it's a completely different work.
Well, speaking from NIH, yes, we would value innovation. Certainly would want that to be part of this. It sounds like that would fit under defining a research agenda. So if through your work you identify particularly promising areas, it would be probably hard to recommend them if they haven't been evaluated. But that could be part of a research agenda. I guess going back to one of the earlier questions, also in terms of the focus of the report. I would say, from my perspective, would be those that are within the recommendations that could be implemented within the health sector. I would think would be a focus, and not something that would be really far afield of what could be implemented by health sector actors.
Yeah, and just to build on the innovation, I think our preference would be to identify innovative ways to apply proven approaches, potentially, or things that have some evidence base already that they work, and then potentially recommending an innovative take on it. So it's not so much purely untested approach, but something that we have some basis to think is going to work, and that can then be the subject of further implementation research, but not so far upstream that we would have to pilot it and that kind of thing.
Just to add in one more thought, I could imagine encouraging a community ecosystem of innovation as a potential recommendation that we're looking at one point in time or over a few months, but to have as part of a recommendation that there be resources dedicated to innovation and to really achieve these goals. Any of our health goals, there would need to be innovation as part of that.
One brief example from PEPFAR is that we're exploring use cases for distributed ledger technologies to improve efficiencies in the healthcare service delivery system. So we have a number of use cases right now with supply chain management and unique patient identifiers. So speaking for PEPFAR, we're always interested in any innovation that can improve healthcare system.
Thank you. Please, Jeanette.
it reflects some of the conversation. I'm sorry. Do you want to go first?
Oh, no, I was done.
Yeah, it reflects some of the conversation we were having in the closed session, but I mean, I do think that there is a fundamental disruption here. If we look at the health system the way that it's currently organized, and if we look at the changes that are happening, in particular by using technology, genomic, and all that, we have the risk of coming up with recommendations that are evidence-based, blah, 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 everything. But in fact, those are things that are no longer relevant, because what is going to happen over the next 5 years is a completely different thing. So I guess my worry is that we will come up with a set of recommendations on how to do best what we do now. In other words, how to improve the health system of the present, but not really to prepare for what is coming. And then there are big questions there. For example, what are the requisites of quality indicators for a system that is based mostly in the households, or is using technology for diagnosis and also for treatment? Is it necessarily to go through the same path in low-income countries, or they can, as we discussed in the morning, leapfrog and go directly, given, for example, the scarce human resources that we have in the world? What do we? How do we basically assess quality in under those circumstances? So we are in such disruptive environment in health system that I'm not sure that if I think we might be missing an opportunity to think to the future and the real problems that we are going to have and we are already having. Another example. You say you want to know what to do in low income settings, middle income settings, and high income settings, mostly low income and middle income. However, the configuration of countries probably is no longer relevant, because what you have is a global community that is poor, a global community that's middle class, and a global community that is high income. And those global communities are not related to country boundaries. And if we keep kind of having a country and treat that country as low income, therefore XYZ, and perhaps it's low income, but at the same time you have three very different communities, and those communities relate much more with the same communities in other countries. So I guess, I mean, I was going to keep quiet, but I couldn't.
Any reflections?
Sure. So on your last point, I think that on the one hand, I think health systems are bounded by countries to some extent, and in terms of grouping countries, one of the things that we've been looking at USAID is, are there different ways to group countries based on health outcome and based on sort of some of these dimensions of equity? And so is there a set of countries or areas within countries or group of people which still suffer from a very high disease burden? And is there a separate set of interventions that you want to address because your number one goal is to reduce the disease burden? And then is there another set of countries where perhaps they have a smaller or a lower disease burden, but there are still issues with financial protection or quality of care, catastrophic expenditures that have a different set of interventions? So I could see potentially grouping recommendations in that sense that doesn't necessarily group towards national lines. I think on the disruption, I agree. I think if we can know what the future looks like, we can provide recommendations for it. If we don't, then it becomes a lot harder. And so, and then one thing I was going to raise earlier is another question I have on sort of measurements of quality beyond health outcome data it would be interesting to sort of hear what your thinking is on standardizations of quality measurement, because I think on the one hand, our work on quality shows that a lot of the improvements come from teams themselves identifying their issues and tracking their issues in order to make improvements and look at it. But I also know that the global community is very interested in sort of these standardized measures of quality, and is there sort of a dynamic tension between those two, and is there a recommendation on it?
Hi, can you hear me?
Yes. Who is speaking?
This is Steve Taplin.
Oh, hey,
I'm
Steve.
watching from outside.
We're hearing
My
you, and you
apologies.
feel free to comment.
Yeah, just a couple quick comments. One is that you're facing a daunting task, and I think the issue of just focusing on the healthcare system without thinking a little bit about the contextual issues and how you've addressed them would get you into trouble. So I think obviously you have to address the context. I hope that we'll see something out of the report that will help people set priorities, because we can get off into all these side pieces without helping set the priorities. So knowing what are the major conditions that are affecting things, knowing when prevention is actually a better investment. So I think in the U.S. we've shown pretty clearly that taxing cigarettes is the way to reduce cigarette smoking, and it's better than getting good at COPD treatment. I mean, not that we want to not do that, but I think helping guide where there are priorities and where it's better to invest in prevention rather than treatment, whether it's better to invest in high quality end treatment or high quality diagnostic treatment. I think some of those kinds of help in where is the evidence that shows where to put your emphasis to maximize health is going to help. I think the final point is that I think some conceptual organization of the report will help communicate where you've put your emphasis and how you've put your emphasis and where we can work. Recommendations without a conceptual organization, I think, will be hard to interpret and hard to use. So I look forward to a well-organized report. Some of the pieces that Peter presented show one way to look at the cancer care continuum, and there's also ways of organizing contextual and how you've addressed them or not addressed them, and I think some things you will not address appropriately.
Sonia, and then Ashish.
So just a quick response to the comment just now. The committee is very conscious of the need to have a very clear conceptual framework. We've already got a draft in place, and the committee is going to be discussing various iterations of that. So thank you for highlighting its importance. I have a statement, and then I have a question for you. As a committee co-chair, I'm noticing, and please correct me if I'm wrong, that the 5 sponsors and your contributions we greatly appreciate and value, and have very different expectations from the committee. I mean, the Medtronic Foundation outlined the importance of NCDs and have a number of different questions, but with NCDs as a reference point. As a starting point to the discussion on quality. Colleague from the Imperial College, building further on their work, are focused on patient safety. The NIH very clearly wants us to give them research priorities in that area, understandably. USAID wants to look at it from the health systems lens, and PEPFAR wants to focus on solutions given your operational mandate. Each one of you is correct in outlining your priorities, but as a committee co-chair, I just want to recognize and for all of us to be conscious that the sponsors have very different expectations. And of course, as a committee, we will try to give you the best. This is just an observation. I also have a question because there was some discussion about the country health systems lens and country specificity. Now, there hasn't been much discussion that there are, in effect, different health systems models. There is the Bismarckian model, and half the world, health systems in half the world, are modeled on the Bismarckian system, or at least various iterations of that system. And then there is the Beveridge model, and at least the 57 countries of the Commonwealth have still elements of the Beveridge model very much fully constructed. And then in the middle, you have another set of low and middle income countries which have somewhat of a mixed model where there are elements of Beveridge, there's a huge private sector interplay with out of pocket payments as a means of financing, and then for the formally employed sector, there are certain imprints of the Beveridge model as well. So, as sponsors, are you cognizant of these broad pockets of health systems imprints, and what kind of quality dimensions do you want to see within these different three pockets?
Okay. So I'm going to just go back to our point of view. I mean, I do feel, but that's just because I am who I am, that if the health systems approach can wrap its arms around the other sponsors' ideas as well. I will just say on the, in particular on the NCD front, because USAID does not currently have funding that's specific for NCDs, recommendations that would be very specific to an NCD program are less useful for us. That's just the way it is. We do recognize, I think, however, that that is a sort of future area that could potentially be of work. And we also, I think, recognize that in terms of looking at chronic care, in terms of looking at sort of how does prevention lead to NCDs from a nutrition standpoint or that sort of thing, that there are intersections with our work. And so I'll just put that out there. As for different health systems models, we are not trying to impose any one particular model on any one country. I mean, I think we recognize that countries themselves align to produce the system of healthcare that they do, and our interest is in working within whatever model is within a country to improve health outcomes. And and to the extent that there are common approaches that can be applied regardless of the model, that's what I think we would be interested in.
So I'm going to be echoing that, and I think especially from the NIH perspective, health financing is not a particular focus or emphasis, and it would be more looking for cross-cutting interventions or frameworks that would apply. And I think that also speaks to the issue of NCD or other diseases that I would say, especially with the focus or the emphasis on universal health care. Whether someone's there for maternal child health or an NCD or an infectious disease, there would be a common quality system or culture that would address that. So I hope that will be helpful in the work that you're doing. And just about the income level, I think primarily the starting point was with the lower and lower middle income countries, but then also in addition to that was to also recognize, as I mentioned, the linkages between lower resource settings even in higher income countries. So I think with that as a focus, that given limited time and resources to focus on the lower resource side of the spectrum, but to recognize that's not necessarily limited by country boundaries, and to look for where there's reverse innovation or frugal innovation that could be applied. And in the same vein, that's really where resources are limited, the greatest importance to provide efficiently and with the highest possible quality, where there's really not room for wastage.
Thanks, Peter. Ashish.
So everybody on the committee usually has a role. I'm the curmudgeon who tries to think about what are our boundaries and what are not. And so let me just respond to a comment that was made on the phone and ask a question. We were talking about the comment that was made that tobacco taxes are if you want to reduce smoking and smoking related disease burden in your population, tobacco taxes are among the most effective ways we know, much more than getting better at COPD treatment. Undoubtedly, that is true. But it raises a boundary question for us, because if part of what we're trying to do is improve the health of a population, I would argue investing in girls and women's education is one of the best things that we could be doing as a society. I would have up front thought that was out of bounds, not because it's not incredibly important. In fact, it's very, very important. It's just not what we are going to focus on. And so here's a statement, but it's really a question, which is, do you agree with the notion that we're going to focus on things that happen primarily within the healthcare delivery system, which is even narrower than health system, because health system can involve lots of things, including all the sort of social determinants of health? Or how much broader beyond the healthcare delivery system would you like us to go? And do you agree that things like kind of broader social policies, educational interventions, tax policies, all of that stuff is out of bounds, not because they're not important, but because we're going to draw those boundaries? So that's just a question for you guys to help us think about.
Well, this is
Steve, go ahead.
I was the one. I was the one that made the comment. I think the point is, for me, and I can, I can't necessarily speak for all of NIH, but I can say that I think it would be important that your recommendations not focus on the improvement of something like COPD when you know that there is another way, a better way. And so I think it's some acknowledgement that there are other forces than improving and tinkering with the healthcare system that are more important in achieving health, and not acknowledging that, I think, would be a limitation in the study. That's my point. Not necessarily to focus a lot of time there, but to acknowledge that those forces exist and they will affect what happens in the health. So doing better at COPD may not be as high a priority as some other factors. That's all. I think it has to be acknowledged that there are contextual drivers that will do better, and then focus within the healthcare system on those factors which are going to have the highest impact.
Thank you, Steve. Peter, do you have other comments?
Really, just to reinforce that and maybe even go a little bit more strongly. I mean, the focus is on the quality of care, healthcare, medical care. So while there may be other interventions that also would achieve a health outcome as a primary or a collateral benefit, the focus is on quality of care.
We're coming to the end of, I'm sorry, Kelly.
Yeah, I just wanted to second those points. I just wanted to make one comment on the healthcare delivery system. And then you said, well, it wouldn't include social determinants, which I would agree with, but I just want to make sure that the healthcare delivery system is including sort of the people, institution, and resources that sort of combine together to produce health. And so could include public, private sector, community level, that kind of thing. Okay.
Great. Vincent.
I just wanted to respond to the issue of Bismarck, beverage, and so on and so forth. In most of developing world settings, the thinking is not so much about the model of financing, but rather the functions. How do we make health financing functions optimal? How do we make revenue collection, pooling, purchasing, and so on optimal to that, so that they can work towards realization of financial risk protection, equity, and quality of care. So the thinking is not so much about the model, but what kind of policy reforms that we can put in place to improve population health outcomes. And talking about that, Kelly raised issues around financing and highlighted performance-based financing, or rather, pay for performance as one of the financing approaches that we can look at. While this is important in improving quality of care and health outcomes in many settings, the danger is that what is incentivized is what providers concentrate on, especially in the public sector, to a point that other services can get neglected, and that is counterintuitive to the quality of care. And the performance-based financing, in a lot of cases, tends to concentrate resources on areas that are incentivized at the expense of other services. Now, the broader thinking is what kind of provider payment systems can draw incentives for quality and contain costs. I think that should be the main thing, you know, but not about performance-based financing and so on. But the most important issue is the kind of social policies that are at play that can improve financing and also ensure that there is equity both in service use and also equity in finance. Because if we talk about systems that are fragmented, these have direct implications on quality of service. Because by fragmentation, I mean different social groups or social wealth groups have different packages of care so that the poor can only access poor quality services because fragmented system is based on ability to pay. And these are the systems that require reforms towards, you know, making services more equitable, both in financing and in use. And you raised an important issue, and I thought you would have gone further, talk about the role of donors in enhancing equity in service use. But you only talked about coordinating, that donors should coordinate technical assistance. I wish you could also mention how donors can coordinate resources. Because at one point, I had a discussion with the Ministry of Health in Kenya, and what is called the SWAP. What is this? What's the sector-wide approach? And they told me, you know what? We can only talk about sector-wide approach if you exclude financing, or rather the financial resources, because the donors do not want to pool their resources together because they want to operate independently, which leads to a lot of duplication and compromises quality of care. I'll give you an example. In the region where I come from in Kenya, the western region, where the 4 counties that are severely ravaged by HIV, 60% of donor funds find their way 60% of donor funds related to HIV are actually consumed within these 4 out of 47 counties. But the prevalence of HIV is still high. So, rather, there's not much difference in terms of prevalence of HIV. So at what point because in Kenya, 80% of donor funds to the health sector is provided by USAID. At what point will USAID and other interest parties come together and say, we'd want to look at financing from one basket? At what point will you come together to say, can we pool our resources apart from technical assistance? Can we also pool our resources to advance universal health care?
Thanks, Vincent. Don't need to respond, but if you have any comments on his question, that'd be great.
So I'm going to make you my spokesperson. I agree with everything you're saying. I think I'll just acknowledge that when we program resources, we have certain sort of mandates and restrictions and ways that we are required to program those resources, and we try as hard as we can to be as flexible as we can and to align with country programs within the constraints that we have. And I know we could probably do a better job of that, but we do try and just acknowledge that we don't just get funds as a blank check to do whatever we want with. So there are other factors involved in that, but I 100% endorse everything else, and I think he said it much more eloquently than I did about the financing.
Thanks.
Yeah, just
Peter,
to
last comment.
Also, in response and to add on to what Kelly said, I think all of us involved with public health are used to getting resources from one source after another over the years as one problem becomes more prominent in funders, whether it's the U.S. Congress or USAID, are providing that. And I think especially within universal health care, there's ways of whether it's resources intended from PEPFAR or for global health security, there's certain parts of a building block of providing quality care that those can go to that will, whether it's for NCD or maternal child health or for pandemic response. When you go to West Africa and say, where is my specimen transportation system or my notifiable disease response system? It's not there because in contrast to, say, Southern Africa, where there were the PEPFAR resources that weren't there to respond to Ebola. But if Ebola had come to Southern Africa, those building blocks would have been there. So I think that's just going to be an ongoing challenge and something that will be hard to resolve with one study in one report.
Well, thank you. Thank you all. It's been really helpful and gave us a lot of guidance, also a lot of challenges. As Sonia pointed out, we heard different things. We'll do the work to come together. We hope we can't tell you much about what we're doing from now on, but you can tell us anything you want at any point, and I hope you'll be wide open in your communications back to us about ideas you've got, other areas of concern. I want to take a risk here of being a little out of order. One of my heroes and a real pioneer, a courageous pioneer in this field is Jim Hyvee, who's with us. And Jim, I can't resist asking you to comment a little about what you've heard, and this must be as much satisfying to you in terms of your vision as it is to me.
I'm certainly very gratified to hear quality is the focus of a discussion at this level of sophistication. And I think that progress in this area really has been palpable in the last 10 years, and I think that it's exciting to see that somewhat accelerating. And to have a group like this that comes to a consensus on issues of quality may seem like a straightforward accomplishment, but I assure you that 10 years ago, we did not have that. And this has been real progress, and I think you should be very proud of what you're doing here today.
It's a tribute to your work too, Jim. Any advice for us before you put the microphone down? Just keep it.
I think the term measurement really needs to be in the back of our minds all the time. Objective measurement of the impact of what we do to improve quality really needs to be the driving force, not what we think we've done, but what we've demonstrated by measurement.
Thank you. Well, with those words, we can transition to the next panel. We have a 15-minute break booked, a lot to do in the other panel. So first, with thanks to the sponsors for your sponsorship and your comments and guidance. Why don't I propose that we get back here a little earlier to give us even a little more time for your session? Is that okay? So let's see, if we got back in the room, in our seats, and starting at 10 after, that gives you a little more than 10 minutes, plenty of time, and give us a little more time for the panel. So please be back in seats, ready to go at 10 after, and the panelists, the presenters will be ready at that point. Thank you again.